Welcome to the deep dive. Today we're really digging into something complex and pretty controversial in fertility medicine, PGT-A.
That's Preimplantation Genetic Testing for Aneuploidy. And we're looking specifically at sources from the Center for Human Reproduction, or CHR. They've been pushing back against its routine use for, almost 20 years now?
Yeah, nearly 2 decades. So our mission here is to unpack why. Why this major fertility center argues PGT-A isn't just, unhelpful for many, but could actually hurt your chances of having a baby.
It's a strong claim, especially given how common the test has become.
Okay, so let's start with the basic pitch. What is PGT-A supposed to do?
Well, the idea is pretty straightforward on the surface. You do IVF, you get embryos, and before you transfer one, you test it.
Test it for what exactly?
For aneuploidy, which is basically just having the wrong number of chromosomes. That's a major, probably the main reason miscarriages happen.
So the logic is, find the embryos with the wrong number, don't transfer those, only transfer the ones that test normal, the haploid ones.
And boom, higher success rates, fewer miscarriages. That's the promise. Simple, right?
Sounds simple, but here's the immediate tension, the conflict we need to address right up front. This test isn't trivial. It costs thousands of dollars out of pocket for patients, often.
Right. And it adds procedures. You have to biopsy the embryo, which has some risk, and then you absolutely have to freeze all the embryos and do a frozen transfer later. No fresh transfer is possible.
And the biggest point, maybe the most crucial one from CHR's perspective,
Yeah.
the risk that you might discard an embryo labeled abnormal, that could have actually become a healthy baby.
That potential loss, that's really the heart of the controversy, isn't it? The ethical and emotional weight of that decision.
Definitely. So let's trace this back. Where did PGT-A even come from? Late 90s?
Yeah, late 90s. And the initial feeling was pure optimism. Like this was going to revolutionize IVF, pick the winners, screen out the problems.
But that optimism didn't last long, did it?
Yeah.
The data started coming in pretty quickly.
It did. Early 2000s, you had these small studies, mostly from Belgium, that were already showing, not much benefit, if any.
So how did the field react, the people really pushing the test?
They basically waved it away, said, oh, that's just old tech,
Old tech, meaning?
They were testing embryos on day 3 of development, which is quite early. And the tests back then could only look at a few chromosomes, not the full set. So the argument was, the idea is right, we just need better tools.
Yeah, so wait for the upgrade. But then came 2007, a big moment, right? The Maston-Brooks study.
Absolutely huge.
Yeah.
Published in a top journal, much larger scale, and it confirmed it. No overall benefit from the PGT-A of that era.
Wasn't there something even more concerning in that study?
Yes. Critically, it showed that for older women, the very group you'd think would benefit most because their aneuploidy risk is higher, the test actually led to lower pregnancy and live birth rates.
Lower rates, wow. That's the opposite of the promise.
Exactly. But again, the dominant response wasn't maybe the core idea is flawed. It was still, it's the technology. It's still not good enough.
So instead of pausing, the field doubled down on improving the tech itself.
Precisely. Which leads us into the next phase, late 2000s into the 2010s. This is where the big technical changes happen.
What were they?
2 main things. First, they stopped testing on day 3 and moved to day 5, the blastocyst stage. Embryos are more developed then, more cells.
Okay. And second?
They developed ways to test all 23 pairs of chromosomes, not just a handful. Comprehensive chromosome screening, or CCS, they started calling it.
So better timing with day 5 and testing everything. Sounds like they fixed the bad tech problem.
That was definitely the narrative. Now we've got it right. Perfect accuracy.
But here's the paradox CHR points out, and it's a big one. The tech got better, more labs offered it, usage skyrocketed, like over half of U.S. IVF cycles started including it.
Yeah, massive adoption.
But according to CHR's analysis of national data, overall IVF success rates worldwide didn't really improve much between, say, 2004 and 2016. They kind of stagnated, maybe even dipped slightly. How does that make sense?
It doesn't if the test works as advertised, and that's CHR's core point. If the tech improved so much, but outcomes didn't follow suit, maybe the problem wasn't the tech quality. Maybe it was the fundamental assumption the tech was based on.
Okay, so what was that flawed assumption? This leads us to a really critical discovery around 2015, right?
Yes. This was a game changer. CHR, working with doctors in Italy, published cases where embryos that PGT-A had definitively labeled abnormal aneuploid were transferred anyway.
Risky move.
Very. But they resulted in perfectly healthy babies.
Wow. Okay, so how is that possible?
It pointed to something the test completely missed. Embryo self-correction.
Self-correction, like the embryo can fix its own chromosome problems.
It appears so, yes. Or at least it can sideline the abnormal cells. An embryo might have some aneuploid cells early on, but as it develops towards the blastocyst stage and beyond, it seems it has mechanisms to either repair the damage or push those abnormal cells into the part that becomes the placenta, protecting the fetus itself.
So the embryo is more resilient than the test gives it credit for.
Exactly. It's dynamic. It's biology. And a single snapshot test, even an improved one on day 5, might be catching embryos during a messy but temporary phase they could overcome.
So ironically, the move to day 5 testing, which was supposed to improve accuracy, might have still been flawed because it didn't account for this self-healing potential.
That's the argument. The test became static snapshot of a dynamic process. And to try and deal with this complexity, the field then introduced a new category around 2016.
The mosaic embryo.
Right. When the test got its current name, PGT-A, mosaic means the embryo biopsy shows a mix of normal and abnormal cells.
But CHR argues that even this category, this definition, is problematic. Why?
Well, think about how they get that result. The biopsy. They take maybe 5 or 6 cells from an embryo that now has like 150, maybe 200 cells or more. And crucially, where do they take those cells from?
Where?
Only from the trophectoderm. That's the outer layer of the blastocyst, the layer that's destined to become the placenta.
Wait, so they biopsy the future placenta, just a tiny piece of it, and use that to judge the chromosomal health of the entire embryo, including the inner cell mass, the part that actually becomes the baby.
That's precisely the critique. You're making a huge diagnostic call based on a minuscule sample from a supporting structure, not the main event. It's like judging a whole book by tearing off a tiny corner of the cover.
That sounds inherently inaccurate, or at least potentially misleading.
It leads to huge inconsistencies. Some clinics will transfer mosaic embryos, especially low-level mosaics, and have success. Others won't touch them. There's no standard because the biological basis is shaky.
Okay, so after 20 years of this evolution, early hope, disappointing data, tech upgrades, new categories like mosaic, what's CHR's final verdict? Sum it up for us.
It boils down to 3 key things, really. 1, PGT-A doesn't improve live birth rates overall. 2, it might actually harm chances for certain groups like older women or those with few embryos to begin with because you risk discarding embryos that could have worked.
And the 3rd.
The whole scientific premise was flawed from the start because it ignored the embryo's ability to self-correct. It treated the embryo like a static object, not a developing biological system.
And then, just last year, 2024, a major professional body finally seemed to acknowledge this.
Yeah, that was significant. The American Society for Reproductive Medicine, ASRM, put out a statement basically saying PGT-A has no proven benefit for improving live birth rates in most patients.
No proven benefit after it being used routinely for decades. That's quite an admission.
It is. Though, importantly, they stopped short of recommending against its use entirely.
Interesting. Now, CHR also mentions procedural downsides, like how PGT-A forces certain things in the IVF process itself.
Right. Because you have to wait for test results, PGT-A requires freezing all embryos, no fresh transfers. That means every embryo goes through a freeze-thaw cycle, and some just don't survive that. You lose potential chances right there.
And it pushes clinics towards other practices, too.
It does. It pretty much locks you into doing blastocyst culture, waiting till day 5, and often pushes towards single embryo transfer, pulsette. Now, those might be good strategies for some patients, but maybe not universally optimal for everyone. PGT-A removes some flexibility.
And this whole situation, this controversy, it's not just academic anymore. It's hitting the legal system.
Yeah, the lawsuits are starting. There was a class action settlement in Australia in 2023 against a clinic over PGT-A claims.
And CHR predicts more in the U.S.
They anticipate suits against the PGT-A labs themselves, likely coming in 2025. The allegations would be things like, making false claims about the test benefits or not getting proper informed consent from patients who ended up discarding embryos that might have been viable.
Before we get into who CHR blames for this mess, let's talk about how this test became so widespread without solid proof. How did it slip through regulatory cracks?
This is really key. It exploited a loophole called the lab-developed test, or LDT.
LDT.
Yeah. Because the test was developed and performed entirely within the commercial labs selling it, It wasn't classified as a medical device needing rigorous FDA approval like a drug would. It was seen as more of an internal lab procedure.
So it bypassed the whole process of having to prove safety and effectiveness to the FDA before hitting the market.
Exactly, which allowed it to spread rapidly based on marketing and clinic adoption, not necessarily on robust independent evidence. A huge regulatory gap.
Okay, that sets the stage for what CHR calls the mess of responsibility. Let's break down who they point fingers at. First, the clinics and doctors.
They're accused of, well, promoting an expensive, unproven test for years, sometimes even making it mandatory, or perhaps using it to screen out more difficult patients to make their clinic's success rates look better.
And CHR actually calls for an apology.
Explicitly, yes. An apology to patients who were potentially misled or pressured into discarding embryos that could have led to a child.
Strong words. Okay, second, the government. FDA, CDC.
The main blame is on the FDA for allowing the LDT loophole to persist for so long for tests like this. And the CDC, which collects IVF outcome data through SART, is criticized for not analyzing or using that data effectively to flag the lack of benefit or potential harm much earlier.
Then the professional organizations like ASRM and SART, the ones setting guidelines.
Yeah, they get criticized for basically letting PGT-A become the standard of care without demanding strong evidence first. CHR suggests they relied too heavily on guidelines from committees potentially influenced by those with financial interests in the test.
Even though ASRM finally admitted no proven benefit in 2024.
Right, but they still haven't recommended against it. They kind of acknowledged the problem but didn't fully act to stop it, leaving the decision and the confusion with patients and doctors.
And finally, the labs themselves, the ones performing and selling the PGT-A tests.
They're seen as primary drivers, using that LDT loophole to market and profit significantly from a test whose benefits were, at best, unproven and potentially non-existent or negative for many. And now, they're the ones likely facing these upcoming lawsuits.
Okay, so we've gone through the history, the science, the controversy, the blame. Let's bring it back to the listener. If you're going through IVF, or considering it, what are the practical takeaways from CHR's perspective? What's their advice?
Their main recommendation is pretty blunt. Stop routine PGT-A. Just don't do it automatically.
And they suggest patients should push back.
Yes. Question it. If your clinic strongly recommends it, ask why specifically for you. Be wary if it feels like a default add-on, especially given the cost and the lack of proven benefit for most. Challenge it if the motivation seems more financial than medical.
So have that critical conversation with your doctor. Don't just accept it.
Absolutely. CHR suggests skipping PGT-A unless there's a very clear, specific medical indication, like if you know you carry a specific single gene disorder you want to screen for, which is actually a different test called PGT-M, not PGT-A.
And what about those embryos that have already been tested and frozen, labeled abnormal or mosaic?
This is crucial. CHR argues clinics have an ethical obligation to tell patients about these embryos and the possibility that they could still lead to a healthy pregnancy, based on the self-correction evidence. Patients should be given the option to transfer them, understanding the potential, rather than just being told to discard them.
Don't just throw them away based on that label alone.
Exactly. The choice should be yours, fully informed.
And CHR has a warning about the future too, right? Beyond PGT-A.
Yeah, they flag the emergence of newer, even less proven tests, specifically mentioning PGT-P. That's for polygenic risk scoring, trying to predict risk for complex conditions like diabetes or schizophrenia from an embryo.
And the concern is
that it's potentially even sketchier, as they put it, that we might see the same cycle repeat. Premature marketing, lack of solid data, exploiting regulatory loopholes before the science is truly understood.
Yeah.
Buyer beware, essentially.
Wow, okay. This has been a really deep dive into what sounds like a 2-decade saga.
Yeah.
High hopes, flawed science, technical fixes that didn't fix the core issue, and ultimately significant financial and emotional costs for patients caught in the middle.
It really has. And I think the final thought, the takeaway for you listening, comes down to this. Biology versus technology. When you're presented with these high-tech labels, aneuploid, mosaic, abnormal labels that cost a fortune and carry immense weight.
Yeah.
Remember the evidence we've discussed today. Remember the documented cases of healthy babies born from embryos given those exact labels. Consider the embryo's own biological resilience, its proven capacity in some cases to overcome these early challenges. Maybe, just maybe, that biological potential deserves more weight than a static, expensive snapshot from a test.